All right. I think I mean, we've talked for about an hour. I don't know if we want to continue and, running out of questions right now. So we could keep going and going, I'm sure. But Dr. Sirajuddin, what do you think?
If I could ask Dr. Sirajuddin a question,
Sure.
in terms of, since he's closer to the medical side of it than perhaps both myself and Hakeem, you're at. What is the consensus among, or not even consensus, but what are, maybe you could share with us, what is the thinking among IM docs or even some of the ID docs that you've talked to? I mean, you obviously are an IM doc as well. Um, where does this end, or where is this looking like it's trending towards? So right now we're through that period of surge, and we're seeing what's happening in places like New York, but what are they predicting epidemiologically wise, a month from now, 3 months from now, 6 months from now? We're hearing talks of there may be a second wave of this in September, October. Could you talk a little bit about the short-term and long-term epidemiology of this?
It's interesting you asked that, because we have several groups we're talking and with other internal medicine docs, and actually we have several epidemiologists here in Oklahoma City. They anticipate this is just an early surge, and the peak in Oklahoma City is probably going to be mid-May.
Oh,
yes,
wow.
yeah. So that's, although theoretically, initially I was hoping and thinking the peak would be probably closer to April 17th or middle of April, but they anticipate closer to the middle of May for it to peak. So if you talk about a peak of middle of May, then you just put that into perspective. So you're looking at about June, July, or close to early August before the whole thing comes down to back to normal. So that is one way you look at it. So that's kind of the worst, the more pessimistic picture I've ever seen in the internal medicine communications. But if you really look at it, if you want to have try to shine some, little bit of optimism, I feel compared to New York and everything like that, I think I'm glad, thanks to the NBA and everything, I think we shut down, although not completely. I think we started doing at least some social distancing, at least since the middle of March. So I feel it would have an impact, positive impact on the timeframes in Oklahoma. Nevertheless, on the contrary, if you look at some of the activity levels and things in the Northeast, people actually are abiding by their lockdown rules a lot more stringently, as opposed to people in Oklahoma City, where when I go to work in the morning, I feel half of Oklahoma are essential workers because the highway is full of cars. Although there is a significant impact, like I can get to work faster than I ever did, like in the last 20 years. But I still feel that people are not abiding by the social distancing, and which is actually, which is detrimental to the fact even some of the people I know, they're still taking it very lightly. Patients as well as some educated individuals, unfortunately. So that's the realistic view if you want to ask me. So some people are still planning on their cruises end of May, which I think is, So from my standpoint, I honestly feel there's a very high likelihood that Hajj will probably be canceled. Now, talking about Saudi Arabia and when they first canceled Umrah, actually, I was planning to go to Umrah with my parents end of March, March 26th. And we had, paid for the tickets. We were looking at how, are we going to go or not? And then Saudi said, this is way before we shut down in Oklahoma. Saudi shut down Umrah early in March. So I think kudos to them. I think hats off to them because they predicted this and they took appropriate advice and they put down the rule, because otherwise it would have been disastrous, because I don't think they have even close the medical facilities or the medical acumen that we have even in the state of Oklahoma, having been to Saudi Arabia a couple of times, So I think by them doing that is amazing. Unfortunately, we didn't get to do that And I think if we had shut down at least a month in advance, we would have probably had more timelines, more in the zone of April. So that's your answer, unfortunately, from what our discussions are, because people are people are getting affected, and your death rate, although is still a little bit, like we had 4 deaths in Oklahoma City yesterday, but our infection rates are just skyrocketing right now. I think we had 170 new cases overnight. So unfortunately, that's the more realistic response if I was to give you. But the optimistic is hopefully end of April. I'm optimistic in the sense, like my clinic, I've told my patients until May 4th, I'm going to completely shut down, no follow-ups. I'm only seeing emergencies or new patients who I don't think, I don't know what's going on with them, Other than that, May 4th is what my tentative going back live is. But talking to several IM doctors and infectious disease, I feel that might still be a little premature.
Yeah, I mean, as ophthalmologists, we've pretty much given up elective surgery until May as well, and it's really changed the way we practice. I had a lady that came in last week with a very bad eye infection. She's was an 87-year-old, and in normal times, we would have possibly tried to treat the corneal ulcer with drops, but and injections and that sort of thing. But that would require frequent trips for her, and she lived about an hour and a half away. And we ended up getting three of the eye doctors together and talking with the patient as well as her son was there, and ended up. I mean, it was a light perception eye. She could only make out light, but we ended up having to recommend for removal of the eyeball, enucleation, and that has been almost never. I've never had to make that decision in my life, but putting together all these pros and cons of treating there, so it's already affected, I think, our treatment and management strategy, and we're hoping to kind of get back into the swing of things middle of May, but like you said, it may be longer than that. But my follow-up question would be, suppose inshallah we're back running June, July, whenever that'll be. Everyone talks about in the 1918 pandemic with the Spanish influenza, there was that second wave, which happened in September, October. Any thoughts or comments on A, the possibility of the second wave, and B, will it be as bad as this first wave we're seeing?
Number one question, unfortunately, there is a very high likelihood there will be a secondary wave. And it'll be less severe. So it really depends on, number one, how we go back to the regular, realm of things, because you don't know where all it is or who's carrying it, or, you still have 80% who can still not have a mild illness and just go on with life, So far, but still the general consensus, infectious disease, IM and everything, don't be surprised if you have a second wave later this next winter, but it should not be anything close to what we have experienced or we are experiencing currently right now. So that's a shortcut answer, because I think there's so much speculation, and since there's no cure.
And then, like every year we get the flu that happens in waves. Could this, na'udhu billah, khuda na khas, happen next year again?
No, actually, see, the flu is a little different. Every strain is different. Actually, even the COVID-19, you have 8 different strains from what I've heard. So they feel that the strains in Italy and Spain are a lot more, how can I put it, a lot worse, a lot more virulent than the strains which are in the US. So it's mutating pretty fast. So you have 8 different strains. So then, I'm not a very big fan of the so-called flus and the flu vaccines for a couple of reasons, because there's so many mutations, and it becomes more like a monetary issue, because how do you expect getting a flu vaccine which is coming from Europe when you're treating a flu vaccine of a strain in the US, which we did actually a few years ago, when we ran out of the flu vaccines. So you have to actually treat it with the current strain. You see what I'm saying? So a lot of things are up in the air. Honestly speaking, I feel irrespective of IM or infectious disease doctors, what the general feel I see listening to news, listening to talking to other physicians and everything like that. I don't think really people have a great handle, other than the fact that we can't even tell how young it is you're going to get affected. We don't even know how old are getting affected. Every time we think about old and immunocompromised getting affected, but everybody in the news you hear about 40-year-olds intubated. You understand what I'm saying? Who's talking about the 40-year-olds? If you talk about 40-year-old men are more affected. Have you ever heard of a 40-year-old woman on the vent? You always hear about, I mean, I'm asking you, but if you go by the hearsay, what you're hearing. So I think there's definite male predominance, especially in the 30s and 40s and 50s. But again, nobody's talking about all of this because I honestly think people don't have a handle. And I'm very concerned that we should not come up with a vaccine that fast and rapidly go into rapid production without much testing. Then you have a bigger problem because you have a false sense of security and possible so-called side effects from some of the vaccines we can get from what we call less finished products.
Could you comment on, since you mentioned side effects and you're a cardiologist, particularly, the president even went so far on record to talk about, Plaquenil or hydroxychloroquine and chloroquine and, azithromycin types of combinations. And I've been hearing from some of my cardiologist friends that they're seeing a huge spike in some cardiac changes like QT interval changes that can happen from hydroxychloroquine. In your opinion, is this an effective treatment that people should rush off to try to get their primary care doctors to get them hydroxychloroquine and chloroquine? People have even talked about using it as a prophylactic dose. And B, as a cardiologist, can you comment on what are some side effects, specifically the cardiac side effects that can happen with unmonitored and unrestricted usage of some of these medications?
Answering the second question first, cardiac effects of all these drugs, you have to worry about the duration of the use as well as the dosage of the use. So taking it for a few days, I don't think it's going to have any kind of significant cardiac effects. Number one. Number two is hydrochloroquine, which is also commonly known as Plaquenil. I see every Tom, Dick, and Harry on it in the last decade or so who's ever seen a rheumatologist. It's been widely used for lupus and things like that. So, so the boiling down to my assessment or my opinion on that question is because I still think there's so many stories out there, and I really don't think there's one particular notion, this is right and this is wrong. If you look at it mechanistically, what are these? They are anti-inflammatory, right? Chloroquine, as well as there's actually on azithromycin, was actually 25 years ago, there was a study, they used it for acute MIs because it cut down on the, for some reason it cut down on the CRP levels and things like that. So those days I was thinking it's crazy. So bottom line is these drugs do a lot more than what they have been approved to do, okay? So how does these two drugs possibly help, COVID-19 illness, especially in the hospitals, in my opinion, is because I talked to you about the younger generation who are having this hyper acute immune response,
The cytokine storm.
Yes, cytokines. So you wonder if these drugs are more for those people, because obviously you're not talking about the antiviral properties. I don't think Z-Pak has an antiviral property, or chloroquine has any kind of antiviral property. Has not been proven yet, because one is what the research tells you. The other one is it really cause and effect? Okay, so I feel the Zithromax and chloroquine, hydrochloroquine are probably going to be more efficacious in the hospital for people who are younger and going through the cytokine storm, going into ARDS kind of a picture. Now, the other question which we did not ask about is there has been several reports, not only is the lungs affected, several people are having myocarditis and going into heart failure as well. So I feel then you go into lung failure, heart failure, you're just really, asking for trouble. So the only first time I really got alerted about the COVID-19 illness was actually, I think 3 or 4 weeks ago, because we were taking it lightly. We were in a health club. I was playing tennis with a couple of my friends, So one of them is a pulmonologist, and he said, "Guys, you got to take it seriously." Because I said, "Why? What do you know?" Because he's a pulmonologist. He goes, "Well, I have colleagues in China, and who I know personally, and they actually in China, and the colleague actually told me that several of her colleagues are on life support and ECMO
Mm.
ventilator. So same age group, 40s, early 50s. So yeah, so then you realize nobody was talking about all that at that time. Even as of 2 weeks ago, talking to some of the other doctors, they still did not realize the severity of the disease. On a finishing note, I know we're going wrong. On a finishing note, there was in the middle of March, uh, one of my daughter's friends, right? This is when Italy and Spain was on alert, not alert zone 2, and their spring break was 1 week prior to Oklahoma spring break. So they were planning a vacation to Spain. So I was telling my daughter Nadia, I was like, hey, uh, do you know that Italy and Spain are, the cases are going up? Are they sure they're going to go to Spain? The answer we got was, well, the dad was an ER physician. He said it's not a big deal, and it's a big family vacation. They went to Spain, came back. Unfortunately, he's on the vent and ECMO right now for the last week since they returned from Spain. So reality, as I said, when our mayor Holt asked everybody to stay at home on the Twitter tweet, there are several people were tweeting back, unfortunately, saying, "It's our life. Don't tell me what to do. I have to support my wife and kids, and I have to do what I need to do. So you can just keep your advice to yourself." Things like that. The only thing I would say as a parting statement is, I thank everyone for doing the social distancing, which is absolutely, absolutely important. It cannot be overrated at all. It's so underrated still. And the only people who are not practicing social distancing right now are people who cannot comprehend. So either they are ignorant, arrogant, or both, or they don't have anybody they know who have died yet. The reason I say yet is because unfortunately it's going to happen,
Mm.
because we are in a very close community. I'm not talking about Oklahoma, New York. You'll have people and they're all going to be affected. So if you think that's not going to affect anybody I think you got to think again. Just somebody who's a friend of my daughter's, and who she actually went there for a birthday party a couple of months ago. She actually saw, just that remote of a relationship really affects me. Okay. But if any one of us are going to anywhere in the world are going to think, oh, it's not going to affect, it's fine, I think we have to think again. So social distancing, social distancing, social distancing. I can't emphasize enough. That's the best way I can end my part of my answer.
Oh, Jazakallah khair. That was very, very good.
Dr. Riaz, doesn't Plaquenil have effects on the retina?
Yeah, yeah, it does. We it does. But usually that's for patients who've taken it more than 200 milligrams twice a day. Has a lot to do with also the body fat concentration, and we know the retinal toxicity happens usually 5 years after taking that. So we as ophthalmologists are usually will see these patients initially baseline after they take their Plaquenil, or they start on Plaquenil, and then usually after 5 years we see them yearly. It can cause some deposition in the retina and damage the layer of the retina called the retinal pigment epithelium, and that can cause some irreversible central vision loss in patients. And I would say in 7 years, I've maybe have seen a handful of patients who actually have had vision loss, and it's usually very minimal. But that's why I was chuckling a little when Dr. Sirajuddin was talking about that every Tom, Dick, and Harry is on this medication, because you're right. It's a very well tolerated medication for a lot of rheumatology diseases, lupus, rheumatoid arthritis, And so the rheumatologists like it because it has very low side effects compared to some of the newer biological agents like the Humiras and the Enbrels of the world. So we as ophthalmologists have some experience with at least monitoring the visual changes of it. And that's why I was more interested in asking Dr. Sirajuddin if he had anything to comment about sort of the short-term cardiac changes. And I guess there's also some pulmonary changes that can happen. But I guess if somebody's taking a low dose prophylaxis from an eye perspective, very low chance of that happening. It has to be more than 5 years of taking it. But nonetheless, I think I would agree 100% with what Dr. Sirajuddin says, is that there's a lot of talk of, oh, this thing will work or this thing will work. And unfortunately, you know, we don't have clinical trials and evidence to prove that it does work. And one thing which I learned today from Dr. Sirajuddin is that we're not even sure which strain of the virus we're dealing with. So what may have worked in Italy or Spain may not work here, and vice versa. And that's sort of really the scary thing. And so I think social distancing, at least for right now, is our only weapon. And I'm glad that Dr. Sirajuddin commented on some of these things, because it was enlightening for me to hear someone with his expertise commenting on these things as well.